I'm going to present a case on cornea, sir. My name is Dr. Ramya, second year postgraduate from Mahatma Gandhi Medical College, sir. My moderator is Dr. Shrikant, sir. Uh, Patient age 57-year-old female came with chief complaints of sudden drop of vision in the left eye and which is associated with pain since 2 days, sir. History of present illness. Patient was apparently normal 2 days back. Had complaints of sudden drop in vision in left eye for 2 days, which is associated with pain. No history of watering, redness, photophobia. No history of trauma. Coming to past history, ocular history, both the cataract surgery was done 20 years back. Vision got improved with glasses after surgery. Patient complained of drop in vision in both eyes 3 years back and was diagnosed to have both the bullous keratopathy, for which right eye corneal transplantation was done with anterior vitrectomy, followed by after 1 month left eye corneal transplantation was done with anterior vitrectomy, and right eye vision not improved after surgery, left eye vision improved after surgery. Coming to systemic comorbidities, known case of type 2 diabetes since 2 years, family history not significant, personal history diet, mixed diet, bowel and bladder habits unaltered, addictions, non-smoker, non-drinker. General examination, patient conscious, cooperative, moderately built and nourished, no pallor, icterus, clubbing, cyanosis and lymphadenopathy.
You
Vitals
can
are
say
normal,
normal. You can
within
say
normal
normal and
limits.
push. Yeah.
Vitals within normal limits, sir. Systemic examination, no abnormality detected, sir. Coming to ocular examination, head posture normal, no facial asymmetry, Hirschberg's test, both the orthophoric, best corrected visual acuity, right eye 1/60, projection of rays accurate in all quadrants, left eye 1/60, projection of rays accurate in all quadrants. Streak retinoscopy, dull reflex was noted. Intraocular pressure, right eye was not recordable, sir. Left eye 16 mm Hg when recorded with Goldman applanation tonometer. Extraocular movements are full in both eyes. Slits and eggs are normal. Conjunctiva normal. This is the picture showing a right eye picture. These are my cornea findings. A centrally placed full thickness round opaque graph noted measuring 7.5 mm in diameter with 10 nylon interrupted sutures noted at 1, 2, 4, 5, 8 and 10 clock hours. Graft host junction well opposed. Superficial vascularization noted 3, 4, 5, 6, 7 and 8 clock hours. Deep vascularization noted at 3, 4, 6 clock hours. Other details could not be assessed. This is my left eye picture, sir. Left eye cornea findings is centrally placed full thickness round graph noted measuring 7 mm in diameter with 10 nylon interrupted sutures noted at 1 to 12 clock hours with one loose suture noted at 4 o'clock. Graft host junction well opposed. Superficial vascularization noted at 5 to 8 clock hours. Diffuse epithelial edema present. One epithelial bulle noted at 4 o'clock. Diffuse stromal edema noted. Multiple descent membrane folds present. A few pigmented keratic precipitates noted on the endothelium. Iris, iris anterior chamber pupil lens details could not be made out. Left eye iris, surgical peripheral idotomy noted at 2 o'clock. Anterior chamber deep and pupil 3 mm circular non-reacting to light. Lens aphakia. Both the fundus examination details could not be made out. My diagnosis for right eye status post penetrating keratoplasty with graft failure. Left eye status post penetrating keratoplasty with acute graft rejection. We started patient on left eye ciprofloxacin.
You can stop. You can stop. You can stop with diagnosis. It is
Okay,
only
sir.
for discussion up to this.
Okay, sir.
Over to you, Dr. Shrikant.
So why do you say that this is graft rejection?
Sir,
Do you want the slides, Shrikant, or we can stop?
No need, no need. No need.
You can stop. You can stop share. You can stop share.
Yes, sir.
Tell me the points to say that this is a case of acute graft rejection.
Sir, post-surgery patient cornea was clear and vision improved on surgery, sir. And since the patient didn't have any complaints post-surgery, since 2-3 years onwards, patient vision was normal, fine, sir. It got improved. Now patient complaints of sudden drop in vision after 3 years, sir. So initially, since patient was fine, so I'm thinking this was graft rejection, sir. Now.
There are points like conjunctival congestion as well as epithelial edema and anterior
Yes,
chamber
sir.
reaction. All
Yes,
those,
sir.
will say that.
Yes, sir.
Okay,
Findings on inflammation present and loose or broken sutures are present and vascularization also noted, sir.
so
These
all
signs
this,
suggest a graft rejection.
all these are the factors to say that this patient might be having graft rejection. So what is primary graft failure? What are the causes? In the right
Primary
eye, there was a
graft.
primary graft failure.
Yes, sir. Primary graft failure is like absence of graft clarity or persistent edema on the day or within 4 days of surgery, sir. That in that scenario, we can tell primary graft failure, sir.
Okay. So now, what are the ways to manage this case? How will you
So
manage?
we can start on topical steroids, sir, and we can give cycloplegics. And if topical steroids are no improvement, then we can start on injection IV methylprednisolone, sir.
Okay. So, what are the types of graft rejection? Types.
Types
Hello?
of, sir.
I am audible, no?
Yes, sir.
Okay.
Sir, epithelial, subepithelial, endothelial, um, and stromal rejection, sir. In that endothelial graft rejection is the most commonest, sir.
Okay. I would request now Professor Vasanta to ask some more questions.
Can I ask one question?
Yeah, definitely.
Okay.
It's all yours, madam. You
Uh,
can ask. Yeah.
Definitely.
In a one-eyed patient, practically one-eyed patient with an acute graft rejection, you have to treat it like a heart attack. So my personal recommendation would be to start IVMP immediately, so that
That's what we did actually.
Mm.
When the patient presented, we started on IV methylprednisolone, and she responded very well.
Yeah.
Third dose onwards, she responded very well. Actually, today also she came for review. Now the graft is really clear and eye is really quiet. That.
Second thing that we should do is remove all the loose sutures. Loose sutures have no role to play in any corneal transplant or anywhere, because once it becomes loose, it's not going to oppose anything. So loose sutures have to be removed to prevent a repeat graft rejection. And also, whenever you see a vascularization in a graft, particularly in a one-eyed patient, then it's better that you step up the steroids, because, and particularly along the suture lines, if you see, it's important that we step up steroids, because we don't want them to land up with a graft rejection. And most of these patients have to be really tutored that they cannot stop the drops. So they, in some remote areas, sometimes they don't get the steroid drops. They stop for a week and then come back with the rejection. So those are very important points that we have to emphasize to the patient to maintain a clear graft.
Thank you for nice treatment tips.
Yeah, and also periodically call these patients so that you can selectively remove areas where it is healed, where you can see a scar and remove the sutures, because sutures are probably the most important cause for graft rejection.
Actually, in this patient, we have been slowly removing some of the sutures, but she was doing very well for 3 years. Then she was lost for follow-up, and once some problem came, suddenly she appeared. He appeared. That's what actually happened.
Vasudha, madam.
Madam?
Whenever you're describing a case of graft, where the keratoplasty has been done, you must explain what you saw on the recipient side. Because see, you don't know, you are not, you have just guessed that it must be a bullous keratopathy for which graft has been done. Okay. So, but it might have been some other condition also. The patient might have had dystrophy and the only cataract surgery might have been done earlier. No. So,
Yes.
on the recipient side also must be fully explained. And when will and as Dr. Sujata said, you must tell whenever there is a vascularization, even in the right eye, I saw some vascularization. So you must tell the relationship between the vascularization and the suture. Loose suture was there, loose sutures were there. So you must clearly mention the where the vascularization is and where the loose sutures are there. And one more thing is, when will the patient get rejection? We have done a graft. Keratoplasty has been done. So when will they usually develop rejection?
Ma'am, after 14 days of surgery, ma'am.
Okay.
Before that, patient will have cornea,
Thank
clear
you.
cornea, and there will be no stomal edema. Initially, vision will be good, and later, after 14 days, patient will have symptoms, ma'am.
Okay. And till when they can get rejection? But this has happened only 3 years later. No? Till when it can happen?
Yes, ma'am. Till 1 year.
This is 3 years, no?
Just sorry, ma'am.
It can happen anytime.
At any time.
So what will you tell the patient? We have
Yes, ma'am.
keratoplasty. Usually for 1 year, we will be following very diligently.
Okay, ma'am.
So we will be removing the sutures as soon as possible. Okay. When
Yes,
will you
ma'am.
remove the sutures? You tell me that.
Sorry, ma'am.
So you have applied sutures.
Yes,
then
ma'am.
Keratoplasty. When will you remove it?
Ideally, after if sutures are healthy, then after 6 months we'll remove, ma'am.
Yes, minimum 6 months you have to wait because you cornea too, the scar must form very well. Then only you
Yes,
must
ma'am.
remove. Minimum
Yes,
6
ma'am.
months. Usually
Minimum
after
6
5
months.
months.
Yes,
So,
ma'am.
so
In between, if patient complains of irritation and if any vascularization signs are noted, in that such cases we can remove in between. Otherwise, we can.
wait. So till 1 year only
Yes.
you are following up very diligently because usually the rejection can occur before 1 year, but it can happen anytime. So what
Okay.
instruction will you give to the patient when you have done keratoplasty? What instruction will you give to the patient?
I'll give instruction to the patient, like when patient will have a sudden drop in vision, any pain, redness. In such cases, a patient mainly sudden drop of vision, then patient should come and see.
Yes. See,
I'll
so
inform.
Madam.
yes, yes.
Can I just add one point?
Yeah.
So whenever we do suture removal, whether it is you have done it voluntarily because the suture is loose or because you're doing a selective suture removal to reduce astigmatism, every time you remove a suture, you have to step up steroids. The patient will be tapered down to 2 times a day, and then you remove a suture, again step it up to 6 times, and then bring it down like every two days, because every time you're dealing with the suture removal, you're dealing with the immune system, and that can produce an immune response, even disturbing the epithelium. Just like giving contact lenses to the patient can cause rejection. So every time you remove a suture, you have to step up to prevent an acute rejection. Like Madam said, you have to explain to them if there is a sudden drop in vision, then you have to come immediately. You have to explain to them it's like a heart attack in the eye. So you have to come immediately.
Yes, ma'am.
Just one more question, Dr. Ramya. You said
Yes, ma'am.
surgical iridotomy. When do you call it an iridotomy and when do you call it an iridectomy?
Ma'am.
Without opening, if you do, what is it
Without-
called? After opening, if you do, what is it called? I am the invigilator, madam.
Iridotomy is without opening,
That means with
peripheral
what?
iridotomy, sir, without opening.
What is that? How will you do? Madam, sorry.
Yeah,
Yeah, go ahead, answer.
I have finished.
சொல்லுங்க.
With laser we will do, sir.
You got a clue.
Laser
Yeah.
PI, peripheral iridotomy we'll do, sir. And
Surgical?
with open surgical iridectomy we'll do, sir.
Madam, can we move on, madam? Yes, no, madam.
Yeah,
And
PA.
Dr. Kavita, you have any questions or one or two comments? Dr. Kavita Lakshmi. Yeah.
A nice presentation. Nice that you brought out this case. I just want to ask, how long will you actually put the patient on steroids or immunosuppressants when they are on a graft?
Ma'am, high risk patients and low risk patients will see, ma'am. And high risk patients and in that also phakic, pseudophakic will divide it like that, ma'am. And according to that, we will give, ma'am. Phakic patients, we have to give a little lesser, ma'am. And phakic patients and pseudophakic patients, we have to give a few more months extra, ma'am. That's the thing. Ideally, like 6 months we can give, ma'am.
It has to be tailored according to the patient, and as Sujata madam has said, when you see a suture, it has to be stepped up, and again it has to be tapered. So it depends upon person to person. Right, nice presentation.
Thank you so much. Pati, you have any single comment to make? Okay, I'll add 3 points. Can you explain again what is the primary graft failure versus a graft rejection? Because this is
Sir,
commonly asked in the exam.
Yes, sir. Primary graft failure is absence of graft clarity and absence of corneal edema.
Okay, I will not let you tell. I will tell you. Primary
Okay.
graft failure is a disease of the donor. Endothelial count, everything is poor. Then only you call it a primary graft failure. Whereas reaction between the donor and the host will end up in a rejection. Okay, that is one point for all of you. And the number 2 point is what I wanted to ask is you have said vascularization. Supposing you have a superficial vascularization with infiltration, what would you call this? Any superficial with infiltration is called?
Yeah,
Answer is coming no before you. Pannus. Okay. What do you call these pannus when you have a keratoplasty done? Okay, I'll go ahead. Immunological pannus. It's an immunological reaction. It can be called. Last question. Today, one presenter said orthotropia. Another person said orthophoria. What is the difference? See, these are simple things, no? You normally say orthophoric.
Yes, sir. Orthophoric.
And I think our Jimmer friend said orthotropia. Ortho position.
Yes.
No, see, basically remember when you see with both, it is in straight, you say orthophoric.
Sir,
But when
one is latent.
when you
One is
cover
man.
one eye, it is not normal, then it will only be orthophoric. Whereas orthotropia, it will be parallel and you will be able to see all the time. The single binocular single vision will be there. It's a small difference, but you must know what is the difference. I think that's good. And Madam will thank both the presenters. They made a very good presentation and the moderators did well and their moderators did very well. So thank you so much.